Hello everyone, and welcome to this video on how to learn to assign evaluation and management codes, which are commonly called just EM codes. So in this video, we're going to look at the different services available for E&M codes. This is not all of them. These are located starting on page 1 in your actual CBT code book. So if you want to open up your code book and follow along as we go through these sections. But E&M codes are used to report a clinician's professional time and services provided to a patient, such as an office visit or visiting a patient in a hospital, or to provide a consultation to a patient at the request of another physician. It is not for a surgery. That's the rest of the CBT manual, or some of the other portions of the CBT manual, which we will go over later as well. So E&M codes are evaluation and management codes. Again, so it's when a physician or other professional clinician who could be a nurse practitioner or physician assistant evaluate the patient, right? Evaluate their diagnoses and their treatment or their management. So how are they going to manage the patient's care? What treatment are they going to prescribe? If it's a medication, if it's physical therapy, right? It's evaluating the patient's diagnosis and then managing that patient's diagnosis with the correct treatment. So these are, again, for the physician's or the clinician's professional time that he or she spent with the patient. And it could be in an office setting, a hospital setting, emergency room, nursing home, wherever that patient is being examined by the physician and the physician is performing those evaluation and management services. So the most common ones probably used in the E&M section are the office or other outpatient. Sorry, I had a typo. Okay, so these are codes 99202 to 99215. These are used when the patient presents to a physician's office, a clinic setting, and receives services. We then have hospital inpatient or observation care. So that's when the patient has been formally admitted into a hospital as an inpatient or under observation, and the physician that you are coding for is providing E&M services to the patient in that hospital setting. Consultations, again, these are when the patient is being seen by the clinician at the request of somebody, whether it was maybe an insurance company that wants a second opinion, another physician who wants a consultation, or a specialist needs to come in and consult on a patient's care. Maybe a cardiologist is coming in for the primary care physician. So a consultation is when that service has been requested specifically for the patient. Then we have the emergency department and critical care. So emergency department services, obviously, are those E&M services where the physician is seeing the patient in the emergency department. Or critical care is when critical care is provided to the patient, typically in the emergency department or a hospital setting, such as, life-altering, like CPR, tracheostomies, ventilations, those things that necessitate the patient to live. Nursing facilities, so if a physician is seeing a patient at a nursing home, whether it's long-term care, transitional care, skilled nursing, any kind of nursing facility, the residents there are seen by the physician, right, every 30 days or whatever their RADs allow is how many times a physician has to come and see a nursing home patient. So those services are under the E&M section as well. If a patient is receiving services at home or another resident, maybe an assisted living or some kind of group home setting, then there's home care E&M codes. There's newborn care for babies in the hospital, right? There's also neonatal and pediatric critical care. So that's, again, in hospital settings where the patient is in the NICU, which is neonatal intensive care, or the PICU, the PICU, which is the pediatric intensive care unit. Preventative medicine. This is very common in, again, the office setting where the patient is coming in for something routine, like a routine annual checkup. Little kiddos who are getting their annual wellness child check, or a yearly physical, right? A yearly pap smear, a yearly exam, a health exam, all of that is under preventative medicine. Someone coming in for just routine immunizations when the kiddos are growing, all of that is part of the preventative medicine visits. So open up your CBT book, and I want you to bookmark the E&M guidelines. These become the most beneficial resource to you as the coder when you are coding evaluation and management codes. So in the CBT book, these start on page 4, and they go through page 12. Now, with that, every section of the E&M section, every category, I guess I should say, of the E&M section has guidelines specific to that as well. So general guidelines are page 4 through 12. And then on page 13, you can see the evaluation and management starts out with the office and other outpatient services. There are guidelines right at the front there to help the coder when coding E&M codes in the office or outpatient setting. Then on page 15, same with hospital, inpatient, or observation services. There are guidelines right there that the coder needs to read. So as you're coding each service type, make sure to review the coding guidelines because some may apply in some situations and some don't. So for example, new and established patients. It's important as a coder that we know if a patient is new or established in most of the E&M scenarios. In, say, the emergency department, a new or established patient is irrelevant. But in an office setting, we're coding based on if our patient is a new patient, meaning they're new to the facility, they have not been seen by that physician or a physician within that clinic for the last 3 years, or if they're established, meaning they have been seen by that physician or a physician in that clinic for the last 3 years. In a hospital setting, we have initial and subsequent, meaning that the patient is here, initial would be day 1, the day they're admitted to the hospital. If they're an inpatient, day 2 would be a subsequent service because it's not the initial day anymore, now it's day 2. So all of those guidelines you need to become familiar with and read through. Some services are reported separately, so you want to make sure and read through the guidelines to see which ones are reported separately. For example, in the emergency department, we can assign a EM level for an ER visit, as well as critical care if critical care was provided by that same physician to the same patient during the same ER visit. We could have a 99285 for the ER visit and then a 99291 for critical care. So every E&M code has a built-in history and exam that's relative to the patient's care, what the physician is working the patient up for, what the diagnoses and the chief complaints are. That is pertinent to what warrants the physician's history and exam that they're going to complete. All of that needs to be documented, but we don't have to use that as part of our code level. So in 2021, the AMA redesigned the way that the E&M office codes were assigned, and in 2023, they followed along with the rest of the E&M coding sections to where now we, the coder, are coding an E&M service based on either the medical decision-making or time, if time is documented. Now, the only exception to that is the ER. We cannot use time in the ER setting because it's pretty irrelevant compared to the big scope of what the patient is receiving and what they're there for. But in an office setting or for a consultation or nursing home visit, if the physician has documented time, you can code off the time, and you'll see as you're going through the E&M section in your CBT book, that time is listed beside the codes. So for example, if you open up page 13 and look at code 99203, which is a new office or other outpatient visit, it tells us that our evaluation and management of a new patient, which requires a medically appropriate history and examination and low level of medical decision-making, when using time, the time is 30 to 44 minutes of total time is spent on the date of the encounter. So if time was documented at 40 minutes that the physician spent with the patient, working on the patient's care, coordinating the patient's care, that would count for a 99203. Or if the medical decision-making was a low level, which we're going to look at how to level the medical decision-makings. But the first step you want to do as an E&M coder, or when assigning an E&M code, is determine the place of service that your patient is being seen at, the type of service. So the place of service would be an office setting, a hospital, a nursing home, and then the type of service would be an office visit or an office consultation, a hospital observation, or a hospital subsequent visit, a hospital discharge. So where the patient is being seen at and what service is being provided to them dictates what part of the E&M section you're going to go to. So on page 1, if you bookmark your E&M section services guidelines, it has all the different choices of where a patient can be seen in the ER, in the office, in the hospital, newborn services. So page 1 to page 3, again, I won't read them all, but look through those, bookmark them, and just become familiar, because first step in E&M coding is to get to the right section of E&M. So E&M office or E&M ER visit, E&M hospital, and then you narrow down from there, from the codes in that section, which ones to assign. So for example, if my patient is coming in to the office for a sore throat and it's a new patient, I know if I go to page 1, I look at office or other outpatient services, it gives me 99202 to 99215. Then I know it's a new patient, 99202 to 99205, so I can flip to those pages, 99202 to 99205, to determine from those 4 codes which medical decision-making or time is documented in my case scenario, in my medical record, to match the code and assign that code level. And again, we're going to do some case studies at the end. So when we're talking about the medical decision making, there are 3 elements the coder needs to think about. And this chart's kind of hard to see. I know it's little, but for the level of the medical decision making, you can see in the purple at the top row, it says, based on 2 out of 3. So you have to have 2 out of the 3 elements met to assign that level of E&M. Meaning, if you look at the code in the first column, the second column has straightforward, low, moderate, high. Then the third column has minimal, low, moderate, high. The fourth column, which is the amount of complexity of data to review, also has minimal, limited, moderate, extensive. And then the last column, the risk of complication, has minimal, low, moderate, high. So 2 of 3 of the number of complexity of problems addressed, the amount or complexity of data to be reviewed and analyzed, and number 3, the risk of complications and or morbidity or mortality to the patient management need to be met to assign the code. So we could not have, say, a low number of complexity or problems addressed, a limited amount and or complexity of data to be reviewed, and then a moderate risk of complication of morbidity or mortality of our patient, and assign a 99204 or 99214, because low and limited are in the row with a 203 and a 213. So 2 out of 3 have to be met. So to assign a 204 or a 214, we have to have moderate number of complexity and moderate decision making for the amount of complexity of data to be reviewed, or moderate complexity of problems addressed, moderate amount and complexity of data to be reviewed. Okay, I'm going to turn on my drawing here. So say we have a low level, like 2 limited or minor problems, and then limited, we have 1 test, and then we had moderate. So this tells us 2 out of 3 have to be met. We could not assign a moderate here because only 1 is met, right? We have 2 met up here and low, so we could assign a low because we have 2 met here. So let's say we have 1 or more chronic illnesses, 1 test, and then prescription drug management. So here we have 2 met, so we can assign a 204 or a 214. Hopefully that makes sense. So again, you have to have 2 of the 3 of the MDMs met. Okay, I want to go to the next slide. Which this slide is really great for having CBT or the AMA explain what the different illnesses are, which were, if we go back to that first one, right here in column 1, the number and complexity of problems addressed. So how do we know what's acute, what's chronic, what's systemic? So here's a nice sheet that comes from the AMA. So an acute uncomplicated illness or injury, the problem is recent, short-term, low risk to the patient, low risk of mortality, a full recovery is expected. Some examples might be a sprain or rhinitis or cystitis. Next, acute illness with systemic symptoms. So these might be symptoms that are general of one body system, like the whole respiratory system, right? Or the whole integumentary system. There might be some systemic symptoms like a fever or fatigue. Some examples are pyelonephritis, pneumonia, pneumonitis and colitis. And then acute complicated injury would be treatment that requires evaluation of body systems that aren't part of the injured organ, and the injury is extensive, such as a head injury with a brief loss of consciousness. And then stable for chronic is the type of problem is expected to last at least a year or until the patient's death. A change in stage or security does not change whether the condition is chronic, and the patient's treatment goal determine whether the illness is stable. The risk of morbidity is significant without treatment. So some examples or some of the chronic conditions you think about, maybe our patient has hypertension or diabetes, cataracts, a BPH, which is benign prostatic hyperplasia. And then there's chronic illness with exacerbation, progression, or side effects of treatment. So with this, the chronic illness is getting worse, it's not controlled, and it's progressing. There's no examples that CPT provided, but maybe it's a diabetic who's not in control, right? We'll have patients where it'll say diabetes in control, and then we have patients where their diabetes is not in control. So that would be a chronic illness with exacerbation, or asthma. Asthma can be in control, or patients can come to the hospital or come to the office, come to the emergency room with acute exacerbation. We have a chronic illness with severe exacerbation, progression, or side effects of treatment. So again, there's significant risk to our patient, and these patients might be admitted. So it might be the patient with severe asthma having a severe asthmatic attack that they cannot get under control in the emergency department after nebulizers, and they admit the patient. Or maybe our patient has had epilepsy and they're having seizures that we can't get under control, so we admit them. So acute and chronic illnesses are the last column that was in that first grid. And these are injuries that pose a threat to life or bodily function. So with these, there's a near-term threat to life or bodily function without treatment, such as an acute illness with systemic symptoms, an acute complicated injury, or a chronic or illness or injury with exacerbation, like acute myocardial infarction, which is a heart attack, right? A pulmonary embolism, which is a blood clot. Maybe our patient has severe respiratory distress, progressive severe rheumatoid arthritis, a patient who is a threat to their self or others with a psychiatric illness, maybe paranoid schizophrenic having an attack, peritonitis, acute renal failure. This was just a great chart that I thought might give you some nice visuals when you're looking at the three elements of the medical decision making. And again, this table is in your CBT manual in those guidelines. So you can always look to those guidelines for more information. Okay, now let's do some practice. So scenario one, Susan Smith is an established patient who presents to Dr. Christensen's office today with a cough, going on for over a week now, and has a fever. The doctor examines the patient and performs a rapid COVID and influenza test, both of which come back negative. Dr. Christensen's assessment is an upper respiratory infection, or a URI, and he prescribes the patient a Z-Pak, tells the patient to follow up in 7 days, if not better. So take a moment, find the code, and then we're going to look at the correct answer. Okay, hopefully you picked 99214 because our patient, if we go back to our level, and let me get my marker, our patient had an acute illness with systemic symptoms, URI, and then there was a fever. And here it says we need 1 out of the 3 categories. So any combination of 3 of the following: review of the results of each unique test, ordering each unique test. So our physician did 2 tests, right? The influenza, and the COVID. So our physician ordered these and reviewed them. So that's 4. That meets the moderate. And our physician also did prescription drug management by giving our patient a Z-Pak. So we are at a 99214. Let's look at scenario 2. Sophie Sells is a well-known patient who was brought into the office today after jumping on the trampoline and twisted her ankle. The mother brings her in to see Dr. Cox, who performs an x-ray of the left ankle, which did not reveal any fractures. Dr. Cox's assessment is left ankle sprain, and he places the patient in a static ankle splint, and the patient will follow back up in 2 weeks. I'll give you a minute, and then we're going to go over the correct answer. Okay, hopefully you picked 99213. So again, let's go back to our MDM table. I will get out my drawing tool. So our patient had 1, an acute uncomplicated injury, right, with that twisting of the ankle. Our physician ordered an x-ray. Which is ordering, then our physician reviewed it. So we have 2 of the following here. And then low risk, right? Our patient did not get any medications. They didn't send the patient for a consultation or evaluation from an orthopedic surgeon. There wasn't concern for any kind of prescription to help with swelling. It was pretty low risk. So our established patient is a 213. So 99213 is the answer for our second case. And now let's go to our last case. Scenario 3, our patient presents to the office today for the first time. So our patient's new, right? There's a clue. Patient's family just moved into town and does not have a current provider. The mother is concerned as the baby is very fussy and has a rash all over his bottom. Dr. Bradford examines the baby and determines that he has a diaper rash. She advises the mom to put Desitin on during every diaper change to help and return in 1 week if the rash persists. So again, I'll give you a minute and then we're going to go over the answer. Okay, so let's look at this. A diaper rash is pretty low, right? It's a pretty minor problem. So let's get out our tool. So we have a minimal or minor problem, amount of data to review. Our doctor didn't review any data, right? There weren't any labs or x-rays, previous records to look at. Tests weren't ordered, and the risk of somebody dying from a diaper rash is very minimal. So our baby was a new patient, so a 202. So our code is a 99202 for that third case.